name is Doug Jutte, and I'm the Executive Director of the Build Healthy Places Network. We're a Robert Wood Johnson Foundation-funded organization with the mission to catalyze and support collaboration between the sectors of community development and health across the country, with the goal of increasing the impact and effectiveness of both of these fields. Today I'm excited to welcome you to our network comments. My team and I created this bi-monthly live discussion series in response to our colleagues who are eager to connect with like-minded leaders nationwide and to learn about the latest in cross-sector collaboration firsthand. In our August Network Commons event, we heard from leaders in the public health field who shared their aha moments, the insights they've gained on the importance of place, neighborhoods, and community development in their work. Today we're continuing this conversation with a panel of medical professionals. You can view our speakers' full bios using the link in your chat box, but I'd also like to provide brief introductions before we begin. First, I'd like to introduce Dr. Lisa Chamberlain. Lisa is an associate professor of pediatrics at Stanford University School of Medicine, as well as a primary care physician at the Ravenswood Family Health Center, a community clinic in East Palo Alto, California. She's also founder and medical director of the Stanford Pediatric Advocacy Program, and has been working for years closely with the health committees of the California State Senate and State Assembly to reduce childhood health disparities. Next, I'd like to introduce Dr. LaMar Hasbrouck. LaMar is joining us today from Washington, D.C., where he's executive director of NACCHO. That's the National Association of County and City Health Officials, which represents the country's 2,800 local health departments. LaMar was trained in internal medicine, and prior to joining NACCHO, he was director of public health for the state of Illinois, and also has worked for over 10 years for the Centers of Disease Control and Prevention. Our third panelist is Dr. Pamela Riley. Pam is an assistant vice president of the Commonwealth Fund, a New York-based foundation that promotes the development of a high-performing healthcare system. A pediatrician by training, Pam was a program officer for the New York State Health Foundation prior to joining the Commonwealth Fund, where her focus is delivery system reform with a particular emphasis on vulnerable populations. And finally, I'd like to introduce Dr. Donald Schwarz. Don is now at the Robert Wood Johnson Foundation, where he is director of the foundation's effort to catalyze demand for healthier places and healthier practices. Prior to his move to the foundation last year, he was deputy mayor for health and opportunity for the city of Philadelphia, as well as the city's health commissioner. He's also a pediatrician by training, and was a faculty member at the University of Pennsylvania, where he was deputy physician-in-chief at the Children's Hospital of Philadelphia and division chair for adolescent medicine. So I want to thank all four of you for joining us today from your offices across the country. And to our audience, please feel free to ask questions throughout the discussion via our chat function. And you can also join the conversation using Twitter. Our handle is @BHPNetwork, and you can use the hashtag #NetworkCommons. So as a way to start our conversation about aha moments at the intersection of health and community development, I can say a little bit about my own experience. So I've spoken in the past about my time working as a pediatrician in a community clinic caring for children from low-income families. That experience led me to take some time off to get a public health degree and to pursue a fellowship in population health. That was all in an effort to better understand the factors that were really underlying the health of my patients and their well-being, what we now call the social determinants of health. My aha moment was really stumbling across the work of the community development sector. As many of you listening know, this is a mature industry really derived from the 1960s war on poverty, made up of largely nonprofit organizations that invest nearly $200 billion per year specifically into low-income communities. These are the folks who build the affordable housing for families, grocery stores and food deserts, charter schools, daycare centers, supportive housing for the homeless, and also invest in small businesses and in social services in poor neighborhoods. The scale of this work and their focus precisely on what many of us in public health consider the most important social determinants was really my first aha. My second was the realization that these organizations do not generally see improved health as a primary outcome of their work. In fact, better health is not generally measured or assessed in any systematic way. With these facts, a huge industry that many of us in medicine were not even aware of that was actively addressing the social determinants of health. And the fact that these organizations were largely unfamiliar with the likely positive health benefits of their work, or didn't know how to measure those benefits, is really what led me to my work today with the Build Healthy Places Network. And try and bring these fields closer together so we can both have a better and stronger team. So with that introduction, I'd like to turn to our panelists, and we have a few questions before we open to our audience. Lisa, I'd like to start with you. You're still a practicing pediatrician at a federally qualified health center, or an FQHC. but you also have a strong focus on policy and on upstream social determinants of health. When did you realize that medical care alone was not enough to keep your patients healthy? And what influenced your path?
Well, during my training, I was caring for a low-income, largely immigrant population, and so I was confronting on a daily basis the social determinants of health: hunger, homelessness, school failure, and really witnessing the cycle of poverty continuing. I would say that my aha moment came in my senior year of residency, and I had been taking care of a teenager, a young girl who, really bright, straight-A student, bilingual, bicultural, just this fabulous young woman, really the future for all of us. And she came in for headaches, not a real complicated complaint, and it was because she needed glasses. And this was a while ago, before we had coverage for kids like her, and I couldn't get her eyeglasses. And I tried, and was able finally to find one person who would do it, but the office was too far away, and she couldn't figure out how to get there. And I just sat back from that and said, this is not going to work for me. If I'm going to continue to work in this clinical setting, which I do to this day, I need to be working further upstream. Like you, I got a master's in public health and really wear two hats in my career, both addressing the clinical issues as well as the social determinants.
That's great. Thank you. And LaMar, you were trained in internal medicine, but had spent most of your career in public health. Can you tell us what influenced your decision to take that path?
Well, first of all, thanks for having me, Doug, and glad to be a part of the panel. Well, I would say initially that I was trained more broadly first in public health. So the aha moment actually came as an undergrad, in understanding that addressing entire communities as the patient is slightly a different focus than addressing one patient at a time as the healthcare delivery system does. So prior to going to medical school, I'd actually had my MPH and that exposure. Since then, I have never regretted that decision because while I believe both are needed, I felt that I could personally make a bigger impact at the population level. So that's where I've really focused my career. And what I've learned over the span of my career, 25 plus years now, is that health is profoundly local. And it is place-driven, and the key drivers, which we refer to as determinants, are way beyond the walls of any healthcare facility and beyond the reach of the healthcare delivery system. So that's where I chose to kind of contribute and to spend my life's work.
Great, thank you. Pam, what was your experience? You started out as a practicing pediatrician, and your career shifted towards healthcare delivery systems for vulnerable populations. Can you tell us a little bit about that progression for you?
Sure, thanks, Doug. And I actually was a practicing pediatrician out in California at the Community Health Center. And day in and day out, similar to Lisa, I was faced with decisions that had everything to do with addressing patients' social needs, but feeling ill-equipped to be able to do that. One of many aha moments for me when I was in clinical practice was one day I was seeing a patient, a little girl who was there for a cold or something fairly straightforward. And just as I was about to leave the room with my hand on the door, that one last question, her mother asked me, "One more thing, doctor, I have nowhere to stay tonight. Can you help me with that?" And it was a moment of, okay, this has nothing to do with why this patient came in, but it has everything to do with why this patient came in. And it was a series of those types of experiences, whether it's around not having sufficient housing or not having enough food in the home or not having money to buy prescriptions, that became over time really frustrating, and I wanted to do something bigger about it more on a policy level. So that's what prompted me to get my master's in public health, and now I'm working in philanthropy to try to have an influence on some of the policies and healthcare delivery systems that can have an impact on being able to address patients' non-medical needs in addition to their needs that are more directly healthcare focused.
Yeah, well, thank you very much. And Dawn, you were an adolescent medicine specialist and a professor of pediatrics at Penn before heading into government service and now foundation work. Did you have a particular aha moment that changed your trajectory?
I do, and it was when I was practicing with adolescent mothers and their infants. We had been referred a new baby who had been discharged from the neonatal intensive care unit, whose mother was 17 years old. And the baby was brought in by the teenager's mother, who looked really very old and sad. She had a disheveled appearance and looked as depressed as anyone I've met. And in talking with her about this baby, who she was holding very tightly in her arms, she talked about how this infant had been discharged from the nursery to her home. The teenage mother, her daughter, was to school, and this grandmother was providing care. And within 24 hours after the baby was discharged, the home's electricity had been turned off. And at the time of arrival in the house, baby came with lots of equipment, all of which was paid by the healthcare system. And I looked at this grandmother and said, you know, how can I be of help to you? And she looked at me and said, you know, I never thought that at 35 years of age I would be caring for an infant this sick, and my daughter would have a third child, and went on and on. And I thought to myself, I was 35 at that point. I can't imagine her life. But more so, I knew that this baby had cost the system a lot. In fact, this infant care in the newborn nursery cost about $1.5 million. And after that investment, we all had failed to think about what was really important for this family to succeed in raising this child. That was the aha moment for me, that we needed to think, as others have said, upstream and differently about how we did care so that we could improve health rather than just investing in the problems that were created by our society not investing correctly.
Yeah, I appreciate your putting a dollar sign on that, Don, as much as that I think can sometimes feel harsh, perhaps. Because I think $1.5 million, and you suggested when we talked earlier that the baby actually came back into the hospital again for another admission.
Yeah, at the time that we saw the child, the infant needed readmission to the hospital, which cost another $200,000, and was again discharged to the same home. We then intervened, and things got a bit better, but it's a shame that people hadn't thought about what was needed for this family, and in fact the circumstances didn't exist for this family to be better and this child to be better earlier in life.
Yeah. Well, thank you for those. I think it's really striking that the aha moments really extended across different parts of our patients' lives, and we all took different routes to get where we are, sort of working now at a higher level. So the second question I have for all of you is to hear a little bit more about your professional experiences. So how have you seen in your different careers the medical sector changing towards addressing upstream social determinants of health? And particularly, what ways have you seen the medical system beginning to partner with neighborhood-level organizations or the community development sector specifically? LaMar, I'd like to start with you. You've been head of the Illinois Department of Public Health and for the past year executive director at NACCHO. Have you seen the healthcare system changing in regards to neighborhood development?
I certainly have, in a number of different ways. I would say globally that there's been kind of a shifting paradigm, and certainly there is a increased awareness and probably appreciation for the determinants of health. I mean, folks are learning the buzzwords and the lexicon, and you're starting to see that kind of penetrate its way into the healthcare delivery system, as well as the community development kind of arena as well. But I think the biggest thing has been kind of changing and shaping the behaviors of healthcare professionals through incentives and penalties, because those are the things that really change health behavior at the end of the day. So, states and healthcare delivery systems have been looking at additional models for reimbursement, cost recovery savings, and certainly the federal policy with Obamacare and kind of shifting from volume to value and really stressing the importance of population health improvement. That's led kind of to a commensurate change in terms of some of the healthcare delivery and how they're partnered with the community. So you'll see additional investments in things like a workforce beyond the walls of the facility. So community health workers, visiting nurse programs, as well as increased investments in health information technology, interoperability, immunization registries at a state level that's being populated locally. So efforts to facilitate the communication and the information sharing, understanding that we're kind of one ecosystem and we have to start working more closely together. So I've seen that over the last, I'd say, 5 or 10 years or so.
Don, how about you? As I mentioned, prior to your joining the foundation last year, you spent a number of years as deputy mayor and health commissioner in Philadelphia. What changes did you see in medicine during that time, and did you see any early partnerships with the community development sector?
I very much agree with what LaMar said, and absolutely the changes that happened with the ACA happened during the time that I was health commissioner. Probably the best example I can give is that the Children's Hospital in Philadelphia invested with the city in the creation of a family and children's health center that was combined with a recreation center and library in Philadelphia in order to think about combining health care with social determinants quite directly, so that providers in the center, which was a joint city Children's Hospital Health Center, which itself is remarkable, those patients could be prescribed, for instance, physical activity at a city-run recreation center, and people who came to the library asking for information about health could be referred right to the health center in the same building and receive care if needed. So that kind of integration and thinking about the importance of integration beyond simple health care, I think, was a substantial change.
And Don, that building is being built right now, right?
It is. It should be done within the next few months.
Yeah, and for our listeners, we're actually, the network is about to publish a case study on this collaboration between the Children's Hospital of Philadelphia and the City of Philadelphia. It's rather unusual, unfortunately, to have a hospital directly contribute financially to the construction of a facility in a low-income neighborhood, but we're beginning to see more examples of that, so we'll make sure we let everyone know when that comes out. Thank you, Dawn. Pam, your recent focus at the Commonwealth Fund, as I mentioned, has been on improving healthcare delivery to vulnerable populations. If you can expand maybe a little bit on LaMar's comments, what impact has the Affordable Care Act had in this area? And have you seen a shift towards place-based approaches or a larger role for communities in addressing their healthcare disparities?
The Affordable Care Act, in many ways, has given us a really unprecedented opportunity to try to improve care for vulnerable populations, and within that, there are some opportunities and an increasingly stronger case for incorporating and addressing the social determinants of health. I think the biggest opportunity right now is the expansion of coverage, the expansion of Medicaid, which benefits low-income populations, not just because it improves access to health care, but also it protects families financially from having to make the choice between getting health care or getting food, for example. So that's a huge opportunity in itself. But coverage is great, but it's not sufficient. We need improvements in how care is delivered, and the Affordable Care Act creates new opportunities and reinforces some of the existing opportunities that were in place to do that. As LaMar mentioned, there are a lot of instances right now of, because of changes in the way that healthcare is being paid for, we're paying instead of per procedure, per test, there's a move towards paying for making people better and doing whatever it takes to be able to do that, even if that means paying for things that weren't ordinarily paid for under traditional fee-for-service system, like services like housing or, you know, buying an air conditioner so that somebody has better air quality at home, or things like that. So there's an increasing movement towards paying for those sorts of non-medical services because health systems and providers and payers are being held accountable for the whole person and making people better. There are also these penalties that LaMar alluded to. Hospitals are being penalized for people who come back into the hospital, you know, in less than 30 days, if it could have potentially been avoided. And because of that, they're looking for ways to invest in community-based services, for example, to help keep people out of the hospital. So there are a number of opportunities right now. Things are certainly moving in that direction. We're seeing it not just at the health system level, but at levels of health plans. For example, UPMC in Pennsylvania is paying for housing because they realize that that's what's driving a lot of the admissions for their patients. Washington State is taking more of a place-based approach with their accountable communities for health, really trying to work across sectors, public health, healthcare, so that all the sectors that make people, contribute to health are working together to improve health outcomes. So we're seeing much more of that now.
It's interesting, Pam. I think all of us had the experience when I was in training that the first people who were let go when the hospital came under some financial strain were usually the case managers, and now those case managers who help patients have a stable place to go when they're discharged have become one of the most important people in the hospital.
Yes.
Lisa, so you're a medical school professor, and you also help run a pediatric clinic in a low-income community. So you've got a broad perspective on these issues. Have you seen substantial changes in the medical care system, or how medical students are being taught about the role of neighborhoods in health?
Yeah, I definitely think the healthcare sector is changing. It's slow, but it's changing. And I think that one of the things that has helped usher in this change has been the obesity epidemic. I think it's been really humbling to physicians that the biggest healthcare challenge that we face as a nation right now is something where we lack traditional medical interventions. We don't have a pill. We don't have something specific that we can prescribe. And this process, I think, has helped us to understand how so much of our health and our well-being is rooted in the community and how powerful the community context is. Deconstructing those roots. Why do our families that we care so much about not exercise? Well, it's lack of space, it's lack of safety, lack of lighting. They're working very long hours for very low wages and lack of time, frankly. Barriers to healthy food, living in a food desert, income, etc. So I think that understanding the root causes of obesity has helped be a part of the shift that we're all describing in coming to have a more profound appreciation for the social determinants of health. For the doctors that are coming into the system, there have been changes to address this. So with our residents, for instance, they work in deep longitudinal community partnerships as a part of their required training in pediatrics. We have community partnerships with our school district, where we've worked to get the vending machines off campus and or locked in the high schools, with libraries to start providing lunches during the summers to families who aren't able to help make ends meet, and start developing physical activity programs. It's just a few examples where, as physicians, we're working directly with these community-based organizations. The last thing I'll say that I think is going to have a big impact happened this last March, which is a shift in the MCAT, the test that all the doctors have to take when they apply to medical school. They've added a new section that tests the applicant's understanding of the behavioral and social sciences, some of the concepts that lie behind behavior change. So I think that the doctors of the future will be oriented more from the start in terms of thinking more broadly about health and the power of community and the power of the patient's community and environment.
Yeah, thank you. It seems kind of remarkable that it took us until 2015 to make that part of the MCAT test. But I think what's really important about what you're talking about, Lisa, is that I was noting in our aha moments that all of us except LaMar had our primary moments after we were already practicing physicians, and to some degree it became a sort of a shock to us. And LaMar, your story was really more about having this perspective going into medicine. And I think what's exciting, Lisa, is that you're describing a system by which the medical students are being trained this from the outset, and I think it will really alter for the positive the way the future doctors are interacting with colleagues across sectors. So we're doing well on time. I have one more question before we turn to our audience and see what they have to say. So I'm interested to hear more about your personal experiences working across sectors. So specifically, do you have any stories about challenges that have arisen while working with neighborhood-level organizations? And if so, how did you overcome them, or how did the institution you're working with overcome them? And do you have any suggestions for approaching these types of barriers for those who want to work across sectors? So Pam, why don't we start with you? Community organizations play a role in helping vulnerable populations stay healthy and obtain the medical care they need, which is one of your goals in the Commonwealth Fund. What challenges have you seen in working across sectors with community-based organizations?
I think as we move more towards the healthcare system interacting with other sectors, that it's not typically used to working with. There are a number of challenges that arise. And I think a lot of them have to do with just totally different nature of healthcare versus a nonprofit or community-based organization sector, just in the ways that they work together, different philosophies, different cultures. There's a lot of challenges to be overcome. But there's a lot of work to be done in terms of really identifying the roles and responsibilities of each party and really defining how they work together best to achieve the goals of improving health and improving healthcare quality and outcomes for the population that both of these groups care about. So one example that we've seen recently is in New York State. There's it's called a Delivery System Reform Incentive Program. That it's a Medicaid reform program that multiple states are implementing. In New York State, they've just started implementing this plan really to transform the way care is delivered for Medicaid patients, really to improve quality, improve performance of the healthcare system, improve health outcomes. They've created these performing provider systems that are networks of healthcare providers tied together with community-based organizations, really working towards trying to improve the health of the particular population that they're serving. However, there are a number of challenges in really defining who does what, and also bringing some of the nonprofits, smaller nonprofits, up to speed in terms of their ability to do things like share information. Do they have the correct information technology? Do they have the resources to invest in a lot of the infrastructure that they need in order to be a partner with, say, a large hospital system? So there are a number of challenges, and I think there's a lot of work to be done in terms of figuring out how do these, in many ways, disparate entities really figure out how to work together. How do they work together? What is the optimal role that each plays in terms of trying to improve health outcomes for the population?
Yeah, I'm going to thank you very much, Pam. And in fact, I want to suggest that our viewers take advantage of a resource we have on our website specifically to this point. We have something called the Impact Grid, which was developed by our colleagues in Stanford, Connecticut. The Stanford Hospital there has been working with the Housing Authority to directly invest. It's one of the few other examples that we're aware of a hospital directly investing in neighborhood revitalization. And they created a really fantastic impact grid, they called it, where they were able to identify all the different parties and would align their work with different goals. But it was this real shared outcome of community improvement and specifically health improvement. And it really helped lay out expectations. And so if you go to our website at buildhealthyplaces.org, under Measure Up, you can actually just search for Impact Grid. And it really tries to help lay that out, Pam. So thank you for mentioning that. Let's see, Dawn, you've played a prominent role both in a major medical center and city government. Do you have any stories of barriers that arose while working to improve the well-being of low-income communities, and how did you or your institution overcome those barriers?
So I am going to tell you that what I have to say is very much in keeping with what Pam said. So that the story I have has to do with the budget in the state of Pennsylvania, which has become a perennial issue, and the incentives on the public sector side for funding the social service support systems in communities and healthcare institutions in communities, those incentives have come into conflict. They have separate funding lines, they're not integrated well in the state budget. And as a result, the two constituencies end up pitted against each other for what is framed as limited resources. What has happened over time in Pennsylvania on occasion is that the healthcare sector and the social service sector have realized that the issue isn't so much there's a limited pot, but that the two pots that relate to healthcare and social services aren't seen as complementary by the legislature. And coming to the legislature at the time of a budget issue isn't the right time to make that argument. So the two sectors have come together to talk to legislators and educate them much earlier in the process about the complementary nature of those two sectors. And in fact, that advocacy agenda for the two sectors has meant that they're able to work more closely together and appreciate how, in fact, they really are complementary. So while it's a challenge to get there and have a common language and a common message, really important, and I think pays off in the long run.
Yeah, thank you. That reminds me, I believe it's Seattle-King County that actually merged several departments into a single department.
Yeah.
For example, public health and housing, because they were running into the same issue you just described, Don, which is competing rather than working together for a shared pool of resources. Yeah, and that was led, I believe, by David Fleming in Seattle-King County. Lisa, how about you? You're currently the most deeply embedded in a local community. Have you personally experienced barriers to your work, or have you seen the Ravenswood Clinic have to overcome obstacles as it tries to serve its full neighborhood and all the residents of East Palo Alto?
So I think there are a lot of challenges that come in trying to get out of our silos and work together. Some of the common ones are always challenges of time and money, kind of our traditional issues there. But one that I've really come to appreciate over the last 10, 15 years is the importance of building trust. And that just comes with time. I think that initially there are a lot of good ideas and goodwill and people get excited, and 6 months later nothing's happened and people kind of go their separate ways. So a longitudinal engagement and building trust is key. That involves a lot of listening, which doctors sometimes may or may not be so great at. And so I think that that's an important step that people can't really leap over. Really important. But I think another challenge for our community is a lack of kind of an overarching and collective vision, kind of a lack of imagination. This idea that if we're really going to help our kids be school ready, that's a challenge in my community. We all need to work together on that. So we need everyone from prenatal providers coming in and pediatricians as well as home nurse visiting. All of it working together would really allow us to build a community where all the kids could be, for instance, if we set the goal, ready to start kindergarten. Right now, everybody's working in different ways and using different terms and language around it, and I think that with a shared vision, we could have more of a collective impact in working together. So I'm excited for the idea that medicine starts moving beyond the traditional clinical walls and partnering in significant and longitudinal ways with the community members so that we can start to make an impact on some of the community's most challenging problems.
Yeah, it's interesting. You and Don and Pam have all referred in different ways to this idea of a shared vision, a shared outcome. And one thing I'll just mention, and this is maybe for our medical audience listening today, is for me, actually, another aha moment, actually, was the understanding of the difference between an output and an outcome. An output in medicine might be the number of patients we see, but that's not our goal, just to see patients. Our goal is to make them better. And so an outcome is, are they actually better off? Are they healthier? The same could be true for community development. Building housing by itself is no good unless people's lives are actually better because of it. So you, Lisa, are really describing what is your real goal? What is your real outcome? Your value. So LaMar, do you have any examples of these types of challenges in neighborhood level collaborations that you've dealt with, either in Illinois at the Department of Public Health or at NACCHO?
I do. One thing that I would say is that when we're talking about building communities and developing communities, there's always going to be a certain level of assets in the community. So, you know, an asset-based community development model typically works better. And one of the assets that I would highlight in this example is really the asset of retail pharmacists, the CVS, the Walgreens, and the others. The audience might be surprised to know that for about 80% of the minority, lower income, even distressed communities out there, there is one of these retail pharmacies within 5 miles of all those communities. So that's a real asset. Certainly in public health, we recognize that when there's a pandemic and we need to have points of distribution for vaccines or antivirals and the like. But one of the tensions that was met with our members who are local health departments is in the immunization space itself, because giving immunizations can be a business line. It can generate revenue. And so there was a little rub between local health departments and retail pharmacists in terms of who's going to give the vaccine for the community. So from my standpoint, then as a state health director, it was just important to get coverage over the entire community. But for the local health department that's struggling, it's revenue. So what did we do? So we brought these folks together. We brought retail pharmacies together with local health commissioners in the state of Illinois, about 100 of them, and we had a session to really understand where the pharmacists were coming from and what they were trying to do and not trying to do. And we learned in that exchange that, number one, they weren't trying to be the health home and take over the business. They were really trying to be an asset. And they were really trying to be a gap filler, given that there are hours, after hours, and convenience and things like that for folks to get immunizations. But in that exchange, we also uncovered opportunities for local health departments, in this case, to work closer with them in terms of referrals. So when a patient's coming in to just get their medicine or just get their shot, how about, let me refer you to your local health department that can be your health home, and give you more comprehensive services that we're not equipped to give. So really the solution was, as often is, building the relationship, having the conversations, really seeing what the competing agendas are, and then finding your way to some mutual, kind of reciprocity in terms of benefiting the wellness of the entire community.
Wow, I really like that example. The idea of the public health departments working with pharmacies and identifying, as you said, sort of shared goals is amazing. And not being competitive, but like you said, filling gaps with one another. Fantastic story. And this idea too, I think too, I've often, my guess is you guys have all been frustrated at times by our medical training and public health training often focusing on risk factors and on deficits, as opposed to, as you just suggested, on assets, on what do people have. Because low-income communities have a lot going for them as well, but they also have a lot going against them. And identifying the strengths is a different approach, sort of a resilience approach. Well, good. Well, thank you, everyone. And we are on time for some questions from the audience. So my esteemed assistant here is handing me a question. Let's see. I'm going to direct this one at Dawn. Is that right? Okay, Dawn. How do you, let's see. How do you get community development and health together? Hospitals understand that investing in housing and other capital projects contributes to health.
So I actually think it's happening, and the answer to that is put out a new way of viewing health care in this country called an Affordable Care Act, and watch how the incentives push healthcare institutions to begin to realize that it's in their interest to think differently about investment. We're beginning to see, and I think the Build Healthy Places Network has a few examples, where hospitals are investing with communities. We know over time that there have been hospital investments, for instance, in supportive housing, where supportive housing represents a product line for the hospital, and that service, combined with a behavioral health service, for instance, or a nursing home service, is reimbursed, so that there's a reimbursement for the housing expense and the medical expense, and that covers the total expense both of capital and operating cost. Now we're seeing hospitals begin to recognize that for population health, particularly if they have a high market share, investing in the infrastructure in communities with communities, so really improving the places where people live, can have a benefit in terms of people needing to come in to the hospital for repeat admissions, to the health of a population that is maintained in an ACO relationship or another managed relationship where hospitals have an incentive to have a healthier population.
Yeah, thank you. Does anybody else have anything they want to add, or we can go to the next question? Good. All right, let's see what we have. All right, this one's for Pam. Let's see. What is the role of healthcare in investing in housing, education, community policing? So really more systemic level investment, sort of healthcare, what's its role in the larger community improvement basis?
I think that's a great question, and one that I don't think we've completely figured out yet, what the balance is between how much the healthcare system is addressing or should address versus how much should be left to outside of the healthcare system. I think from the healthcare system perspective, I know that the perspective is very much, we're not going to fix the social determinants of health. Even though we should be addressing them, I think there's a need to put some parameters on it for the healthcare system that, even though ideally we would fix poverty, that is probably beyond the scope of what the healthcare system can and is, optimally should be doing. But what the healthcare system should do is think about what is the role of the healthcare system in addressing these things, either in connecting people to services, or if the system can afford to provide them and has a way to provide the services directly, then fantastic. If not, what should the role of the healthcare system be in either getting somebody else to provide these services, referring people, or connecting people to services in a more formal way? I think there's a lot of work to be done in figuring out what that optimal role is, but it depends on the system, at what level you're talking about. If it's an individual healthcare provider is going to be able to do less than, say, a managed care organization or a state Medicaid program. The larger systems might be able to do more in terms of actually providing and paying for the services, whereas on the smaller side of the spectrum, an individual provider or healthcare organization might be better at referring people or forming partnerships or that sort of thing. So, I think it just depends, and there's examples all across the board of how this looks. In the middle, there's managed care organizations, Medicaid managed care organizations in particular, are doing a lot around trying to figure out what their role is, and in some cases paying for these services. A lot of which is around housing, sometimes around things like education, financial assistance. So I think there's a spectrum, and it sort of depends on what the particular capacity of the organization is that you're talking about.
Yeah, and I think you're highlighting that. Well, two things really. One is that the healthcare system alone can't solve poverty any more than any other sector can solve poverty. So we can't entirely expect that. And this is very much in movement right now. This is a very much a changing field. I wanted to actually answer related. One question that just popped up I noticed on the chat is, to be clear, hospitals do more often invest in the medical system, more often invest in services. But the examples we provided of the hospitals, for example, the Children's Hospital of Philadelphia and the Stanford Hospital, those were capital investments in the actual building of infrastructure. Those are relatively unusual and the types of things that we're trying to highlight and identify examples of. And actually, LaMar, I was curious just on that question, because this is such an important one. Do you have anything you would add about the role of the healthcare system in investing? Again, it can't be the healthcare system. It's already spending. It doesn't feel like it has extra money, and yet the value of healthier people is important to it. So do you see a balance there, or what do you think?
Well, I would say in a word, partner. Healthcare delivery systems, hospitals, critical access hospitals, whatever, community health clinics, need not recreate assets. Again, it starts with the assets in the communities, and I think that they really need to be better partners in reaching out to local public health or social services or private investors and the like to really address those larger issue things. They need to be incentivized to do that collaboration. They need to be penalized for working in isolation. They need to develop systems to share information. They need to overlap different maps of social service gaps and built environment gaps and transportation gaps. They just need to work smarter, not necessarily harder, not necessarily spending a lot more investment. They need to invest the time in building the relationships and learning the other sectors in their community, and really focusing more outside of the walls of that facility and their attributable population, but looking more in terms of the catchment area of the geographical population that's bigger than the hospital. Understanding that a patient may have 4 touch points a year in that facility, but are going to have to live the other 361 days in their environment. So I think partnership is really going to be the key for healthcare delivery systems, hospital executives, and the like. And we're finding and working and surveying our members that we're starting to get some traction, but in many cases, the local health commissioner if you will, does not have a relationship with the hospital executive or critical access hospital executive or even FQHC director. So we got to start bridging those relationships, and then rather than poaching staff from works traditionally in public health, actually partnering with those folks so that you can have synergistic activities towards the same goal.
Yeah, it sounds like a lot of there's value in just different organizations meeting one another and getting to know each other better.
That's right.
All right, so Lisa, I've got one for you, and maybe LaMar if you have something to add. So beyond the ACA, what are other policies or federal or state programs that can be leveraged for the cross-sectoral work that we want to see that addresses social determinants of health?
I think that one thing that has really emerged out of the ACA is people are looking at the community benefit that nonprofit hospitals are required to spend and invest in their communities. And they're really being asked to do more of the asset mapping that LaMar is talking about and community needs assessments to understand what are the priorities in the community, who are the leaders in the community doing great work, and how can the either children's hospital or adult hospital start partnering effectively to address some of those concerns. So I think that has created a real sea change in terms of hospitals thinking, wow, I need to understand more what's going on beyond the clinic walls. So I think looking deeply at the community benefit requirement of hospitals, who are the people running the community section of the hospital, those are going to be some of the allies that the leadership in public health could be reaching out to initially. Because those are going to be kind of the most like-minded folks. So I think that that's one new policy that has immediate traction and is already underway.
Anything you would add, LaMar?
Sure, I'd agree with Lisa. I'd also add, there's been, I would say, renewed interest in the policy around health in all policies, and that is looking at through a health lens when you're talking about transportation, built environment, urban planning, green spaces, looking at it through a health lens. There's a recent IOM report that looked at disasters as an opportunity when you're responding after the disaster and you're in the kind of the recovery and rebuilding phase. There's often an opportunity to really assess what was missing there pre-disaster and to try to kind of right-size some of those things. So if you're talking about a community health center or green space, getting rid of lead-laden housing, other things like that, it's actually an opportunity to address those things, and often in an expedited way, because after a disaster you have an influx of resources, FEMA resources, for instance. And so there's opportunities to start building communities or rebuilding communities in a way that really puts health at the center, and looking at how your decisions in rebuilding in this instance are going to impact or facilitate health and wellness for a community. So health in all policies is certainly a policy that I think is, at the federal level, we've attempted to do it with the Surgeon General and Secretary of Health, but I think at local levels we're starting to see that be entertained as well.
Yeah, it's funny. One thing I'll add, I think the importance of the health in all policies is that we consider, obviously, health as an outcome, good or bad, in fact, of different approaches. One thing I've noticed, though, and for our community development audience here, is that no one wants to be thought of as the wraparound service for another sector. So for, in fact, those who work in housing think of health as a wraparound service, whereas those of us in health think of housing as a service related to health. And so I think sometimes we have to be a little careful about even the term health in all policies is we risk a little bit pushing down health onto other sectors. But the idea, I think, is really critical, actually. Do we have time for another question? We do. All right. So, oh, wow, this is one that could be for any of you. Do you have examples of Medicare, managed care or Medicaid plans that are actually investing in housing and social health? Let's see. Or other ways, actually, of healthcare partnering with housing developers. So we've talked about a few, but do you have other examples that we have the time to highlight in terms of Medicaid managed plans or other healthcare partnering with housing or community development? Anyone have an example we haven't heard yet?
I can take that one. So I mentioned UPMC in Pennsylvania that's actually doing some work around providing housing to some of their more higher utilizers.
UPMC is, what's the organization?
It's called UPMC.
Okay.
Don't ask me what that stands for.
It's in Pittsburgh.
Yes, but also out your way in California, Health Plan of San Mateo is actually doing a lot of work investing in housing for their dual eligible beneficiaries, people who are covered by both Medicare and Medicaid. Seeing as there's a lot of recognition that that is a driver of utilization and costs in the healthcare system. So, but just more generally, Medicaid managed care organizations are a big sector that is looking at this because there's a lot of opportunity for them. There's a need given their patient population and given the way that their payments to providers are structured. It's a capitated structure, meaning that they give providers sort of a lump sum, and there's room within that lump sum to take care of some other things that are contributing to high healthcare utilization or high healthcare costs that there wouldn't otherwise be room to pay for. Just a couple of plugs. The Association for Community Affiliated Plans, or ACAP, released a paper on this last year, 2014, doing a review of Medicaid managed care organizations that are investing in social determinants of health. The Commonwealth Fund is also funding a project in this area. We are funding Laura Gottlieb at UCSF and Rishi Manchanda of Help Begins to do analysis of Medicaid managed care organizations and how they're making the business case or value case for addressing social determinants of health. So that's forthcoming.
And I would say the social impact bond that is being looked at for green and healthy homes, where the ultimate payers on the bond are likely to be either Medicaid managed care plans or large Medicaid providers. And there it's an investment not so much in affordable housing, but in housing quality. Both are clearly important.
Yeah, thank you for mentioning that, Don. So the social impact bond, many of you would be aware that's a form of pay for performance or pay for success, and excuse me, is some of the work that the Federal Reserve System, who has been partnering with us on some of this work, is trying to identify ways in which investment can occur more directly. And there's talk of how do we create a market that values health. So right now we have a market that in many ways values illness. So hospitals stay afloat by keeping their beds full. And the stock market relies on pharmaceutical companies and on device makers, that sort of thing. So how do we use those same tools but towards health? Let's see, I've got another question here. Maybe Lisa, we can start with you. How can we overcome challenges when sectors are talking about the same things but are using different language?
Yeah, I think that is such a challenge. I remember at one of the very first community development meetings that we attended together, Doug, people were talking about the CDC. And Lynn Symes stood up and said, so when you're saying CDC, you're not talking about Atlanta, are you? And everyone laughed because obviously from a medical perspective, we think of Centers for Disease Control and Prevention, and everyone else in the room was talking about Community Development Corporation. So I think that it goes back to the comment I made earlier about a longitudinal connection to each other. With time, that language can start to be understood by each other. But beyond jargon, I think it's understanding a shared goal. And when you have a shared goal, we may need to create some shared language around how we try to move in the same direction and define our own terms together. So I think it's not necessarily, while it can be a barrier, I think it might be part of the process in terms of creating solutions.
Yeah. Anybody else have any comments about this issue of sort of language and terms that serves as a barrier to working together? One thing we do have here, and it's actually now on the site. It's not. We will soon be releasing. It's actually just being finished right now. It's what we call a jargon buster, and it will be again on our website. And the goal is to identify some things, like Lisa said, the CDCs and the CDC. But there's a number of other examples. But there's also just ideas. The idea of Community development is a kind of a broad, vague term that is used specifically by some people and generally by others. And even the term, interestingly, healthcare or public health is often misunderstood by those who are outside of that field. So keep an eye out for the jargon buster. And I think we're all right. So it is getting close to time to wrap up. So let's see here. All right. So in closing, I want to thank each of our speakers today for taking the time to share their own personal experiences. I also want to thank, of course, our audience for providing such great questions. And I noticed the chat box has been full of comments and some people even answering or questioning the comments of others, which I like. We have over 250 people registered today. So thank you again for participating. So I'd like to ask one closing question of our speakers. So as a physician myself, I can say that for doctors seeing patients, the idea of dealing with these larger community level issues can feel daunting and beyond our training or skill sets. But our goals, as we've mentioned, are of healthier communities and families are shared with our colleagues in development. So for each of you, what's one piece of advice you would give to our audience for working across sectors, either interacting with doctors in the medical system, or for doctors, how would you reach out to community partners? So Don, I'd like to start with you.
So I guess I would say this is not easy work, and it's not going to be done quickly. So patience is a major virtue here for anyone who is wanting to make a difference at the intersection between health and healthcare. But I think there's a huge reward. So be patient, hang in there, be a good listener.
Thank you. Appreciate that. Lisa.
I would say for the physicians out there to really pay attention to what makes you angry. What are you so frustrated by that you're seeing over and over again? That is your issue choosing you. And I would encourage you to answer that, to follow through on that, to look into the community, to find those assets, people who are addressing that issue, sitting down with them and saying, you know, how can we partner? How could I be an asset for you? And vice versa. And to the public health professionals, I would say that physicians inherit failed social policy. The failed social policies out there come walking through our doors on a daily basis, and we have access to repeated touchpoint access to a lot of the folks that you're having the hardest time reaching. And so I would say that you know, again, reaching out to some of the doctors and saying, where's there an opportunity for leveraging and working together? So those would be my thoughts.
Like that, harness your anger. It also gets to the point of you can't deal with everything. I think, Pam, you do that. So really focus on the one thing that you want to drive towards. LaMar, what's your one piece of advice?
Well, I would say, if I was speaking to an individual doctor, I would say the best thing that I would, the best advice I would give them is to be an advocate of working across sectors, because everything you do on a daily basis is not going to count for much if you're sending them back to an ecosystem or a context where they can't be compliant, they can't do the other things that you want them to do in between visits. So it's like throwing one starfish back at a time, and you're just not going to make any headway in terms of these broader contextual issues. So be an advocate in your role for that healthcare delivery system in bridging gaps between those who are working in population health and those who are working in these other sectors that are so important for allowing and enabling your patient to be well and have a chance at their human potential. That's what I would say to the individual physician. To the system, I would say continue to broaden the tent using multi-sector sector approaches to improve the ecosystem. Number two, incentivize collaboration and penalize redundancy. And then number three, I like the pay for success and social contract models, because some of these upstream things can be very hard to demonstrate. And so paying for success, you're paying first and then you're reimbursing based on success. And I think that's probably a much better way to go.
Oh, thank you very much. And Pam, let's end with you.
Sure. So my one piece of advice is probably more for the community development sector. There's a real opportunity right now on the healthcare system side to make the case for why working with community development matters. I think there's a lot of recognition because of the changing incentives in the healthcare system that people are going to have to start addressing social determinants of health, and there's a lot of question about figuring out how to do that. But taking it a step further, there's less of a drive to really go a step further and look at the role that community development plays in that. I think the community development sector could help by really making the case and illustrating how do benefits accrue to the healthcare system directly from community development activities, sort of making that, like, how does it contribute to better health outcomes, better outcomes for the patient, better outcomes for what the healthcare system wants to see, and the community development sector, if they're able to illustrate that, could be able to make some headway in terms of better integrating with healthcare delivery.
Great, thank you, Pam. You're speaking our language. So thank you all. We need to close. So again, thank you, Lisa, LaMar, Pamela, and Don. I want to thank everyone who listened in as well. I encourage everyone who's listening to continue to share your questions or comments via Twitter using the hashtag #NetworkCommons. And we'd love to hear suggestions for future events as well. There will be a short post-event survey will pop up after the broadcast ends, and we'd appreciate you taking a moment if you have a chance. If you missed any of today's discussion, we'll be posting highlights on our website or on our YouTube channel, the Build Healthy Places Network YouTube channel. And I've mentioned our website, buildhealthyplaces.org. We have blog posts, case studies, and specifically actually to your last point, Pam, Measure Up is our new resource that provides tools on metrics, measurement, and best practices from across the industry. So if you haven't yet, please sign up for our newsletter. It's called The Pulse. It's a monthly roundup of what we think are exciting conversations in the field, and we look forward to seeing everyone again at the next Network Commons. Thank you all.